Yeah, so today we are going to be starting with the bacterial infections, and we are not wasting too much time. We are just going straight to the point. We already know the layers of the skin. The outermost layer is the epidermis. Then next to it, we have the dermis. Then beneath the dermis, we have the subcutaneous fat. Then the muzzle. So we can have infection affecting one of these layers or even more than one of them. For example, you can have infection localized only to the epidermis. You can have infection affecting the epidermis and the dermis. You can have infection affecting, the epidermis, dermis down to the subcutaneous tissue, and sometimes some can even get to the muscle. So, and sometimes you can also have infection affecting the appendages of the skin, for example, the hair follicles, in situations like folliculitis. Okay, so let's take them one by one, and we are going to be going from superficial to deep. So the most superficial infection is impetigo. Don't forget, the infections you are looking at now are bacterial infections. So impetigo can be caused by a bacterial infection, and it is a local infection of the epidermis only. It's common in children, so it's only children that usually have impetigo. And what are the two major organisms we need to remember when it comes to impetigo? The group A streptococcal infection, which is our streptococcal pyogenes, and the Staphylococcus aureus. Staph aureus, group A strep or Staphylococcus or Streptococcus pyogenes. Sorry about that. Let me come again. Streptococcus pyogene, which is an example of a group A Streptococcus, and Staphylococcus aureus. Those are the two major organisms implicated in impetigo, and we must be able to differentiate between them because the presentation of the lesion is going to be variable. Another point to note about impetigo is that it is very contagious, so you have to treat and isolate that person. So you isolate, you treat. Then once you start your treatment, after 24 hours, you can, tell the person the baby or the kid to go back to school. Because after 24 hours of commencing treatment, the child is no longer infectious. The most common route of transmission is by direct contact. So let us look at the types. We have two types of impetigo, the bullous type and the non-bullous type. The first thing I'm going to say is that the non-bullous type can be caused by both group A strep and Staph aureus, while the bullous type is majorly caused by Staph aureus. What do we see for the non-bullous type? This is the lesion. So we are just going to see like pustules and honey-colored crusts with an erythematous base. So you are just going to see like pustules, like just like papules containing pus, and later they are going to rupture, and the pus is going to form crust all over the lesion. And of course, you are going to see an erythematous background. So once you see something like this gold color yellow crust over a lesion in the face, think about non-bullous impetigo, because it's very common in the face, like particularly the sides of the nose, the mouth, the ears. That's where you see non-bullous impetigo in a child. So you see that kind of lesion in a child, you have to have a very high suspicion, for group A strep causing non-bullous impetigo. Okay, or Staph aureus causing non-bullous impetigo. Before I move, though I'm still going to talk about the treatment, but it's good for me to chip it in so that the more I say it, the higher the chance it's going to stay. When the infection is limited, it is just mild. You give topical. Just apply it to that area because it's mild. You can count the number of lesions you are seeing, maybe one or two. Just apply your topical mupirocin. So mupirocin is an antibiotic we are going to be talking about a lot of time with respect to this bacterial infection of the skin. Mupirocin can cover both group A strep and Staph aureus, so it's wonderful. You don't need to even know that what is the causative organism. Once you see it, just give your topical mupirocin. But when it's severe, you have a lot, it's widespread. So you need to give oral medication. What oral medication are you going to give? Oral cephalexin. It is a first generation cephalosporin, and it works for both the strep and the staph. So very important to remember that. Dr. Miriam, are you raising your hand?
Yes, please, I want to ask a question. So for this treatment, is it for the non-bolus and the bolus or just for the non-bolus type?
For the non-bolus. We are still looking at the non-bolus. Though
Okay.
there's some degree of overlap. You can use these two for the bolus, but the only problem with the bolus is that bolus is categorized as severe. So there's nothing limited about once it is bolus, it is a severe infection. So that means that there's no place for using topical mupirocin. Just imagine somebody's having a bolus lesion, you are applying topical stuff. You need something to penetrate that lesion. So you give oral cephalexin in that regard. So that's that about the non-bolus. Don't forget the two major organisms, staph and the strep. Both of them can cause non-bolus. Both of them. And what are you going to see? The pustules that rupture and form the honey-colored crust. You can find these in the bolus. You might not find it. So this is the honey-colored crust, in the face of a child. For the bolus type, what you are going to see is going to be flaccid bullae. So you are going to see flaccid bullae. Let's see if I think I have the image here. Open now. What's happening? Okay. So these are the bullous lesions. You can see this more than 1 centimeter fluid-filled blisters. They are called flaccid because they have a very high tendency to rupture. They are not tensed. So, do you guys remember a dermatological condition that can cause tense bullae? Anybody remembers? Very common in adults. Tense bullae.
That should be.
Which one is it? It is autoimmune.
Yes.
Bullous pemphigoid.
Yes,
Bullous pemphigoid.
yes.
But if it's flaccid, pemphigoid vulgaris. So
Nice.
you are going to see fluid-filled blisters, that are flaccid and they have a very high tendency to rupture. And when they rupture, you can see some of those discharge will be there, and the discharge is going to spill out, leading to formation of scales, and you call these scales collarette of scales. So you can see this scaly lesion surrounding the blisters. You know that this is bullous impetigo, and the organism that is causing this definitely is Staph aureus. So this is a severe form, and you don't give topical mupirocin. So you can give this person cephalexin, oral cephalexin. Um, so the Nikolsky sign is usually positive in them. Don't forget that. So that means that if we apply pressure over that area, that blister is going to unroof easily. It is caused by Staph aureus, particularly the ones that produce the exfoliative toxin. So this same exfoliative toxin producing Staph aureus is also the one that mediates the staphylococcal scalded skin syndrome. So that is why an individual that has this bullous type of impetigo can easily evolve into developing the staphylococcal scalded skin syndrome. So don't forget that. And also the Nikolsky sign is also positive in the staphylococcal scalded skin syndrome as well as the bullous impetigo. Moving on. So we are going to talk about staphylococcal scalded skin syndrome now, and it's important to know that it is one of the complications of impetigo. Just like I've said, the bullous type can progress, to the SSS. And what are you going to see? I don't think I have an image here, but you just need to know the clinical presentation. Once you know the clinical presentation, you are good. The first thing is the child, because it's very common in child. We said impetigo is common in child, and SSS is a complication of impetigo. So that means that this should be common in children too, but it can happen in adult too. Very rarely, particularly adult with renal insufficiency. So you see an adult that's having SSS, think about renal insufficiency, look out for the electrolytes. So what are you going to see in the question step? So the question is going to tell you that somebody develops fever initially, baby or the child, develops fever, irritability, and tenderness in the skin, right? Then subsequently, there's generalized erythema. They have not still said anything that should raise our suspicion for SSS. But after that erythema, we are now seeing flaccid blisters or bullous lesion that is located within the flexural areas. Sometimes I don't really pay attention to the area. It's not all the lesions that you need to know the areas. For example, this SSS now, the areal is not very, very important. You just need to know the lesions. But if you are talking about dermatitis epiphyseal, you cannot afford not to know the location. Or you are talking about psoriasis or lichen planus, because the locations will give out all those ones because they are very, very similar. But something like SSS is very classic. You have a young child that present initially with fever, irritability, skin tenderness, and the baby develops diffuse erythema. Then later you have flaccid blisters or bullae developing from the body. Flaccid blisters and bullae developing from the body. And they now tell you in the question again that the baby has perioral crusting. But we need to be careful here. SSS does not affect the mucosa. So that means that it's not going to be affecting the mouth itself. It's not going to be affecting the conjunctiva. It's not going to be affecting the genital. No mucosal surface is affected. Don't confuse the perioral crusting for mucosal affectation. It's just around, they will tell you in the question, around the mouth, not in the mouth. So that kind of progression, the flaccid blisters or the bullae with perioral crusting, sparing the mucosal surface, you are thinking about SSS. Very easy stuff. If you apply pressure over the bullous lesion, they are, they are kind of getting destroyed. They are sloughing off. That is your Nikolsky sign. So your Nikolsky sign is also positive in the SSS syndrome because the staph aureus that is causing it produces the exfoliative toxin. And what does that toxin does? It affects the desmoglein 1 that connect the intraepidermal cells together. So let's assume that we have like the epidermis now, and of course we have like 4 or 5 layers there, and they are kind of adhered together. Your stratum spinosum is attached to your stratum basale. Your stratum spinosum is attached to your stratum granulosum above. Your stratum granulosum is attached to your stratum lucidium or corneum above, right? This desmoglein 1 kind of mediate attachment between the stratum granulosum and the stratum spinosum. So it means that once you have production of this exfoliative toxin, that toxin is going to destroy that desmoglein 1, and you will lose attachment between your stratum granulosum and stratum spinosum. Once there's that detachment, that means there's a potential space. Fluid is going to accumulate, and it will lead to formation of blisters. That's very, very easy to get. And the reason why the blister is going to be flaccid is because it is accumulating intraepidermally. There's nothing to cushion it and support it. Once you apply finger like this, just, sloughing off, Nikolsky positivity, right? And later you now notice that the skin is appearing scalded, as if somebody has a burn injury. That is SSS. What do you do? Because you already know that Staphylococcus aureus is an implicating organism, you give anti-staphylococcal antibiotics. Very, very important. Don't make the mistake. Anti-staphylococcal antibiotics. And what are these antibiotics? Your nafcillin or your vancomycin. and you do your supportive wound care. So all those blisters that have ruptured, you can apply your hemollient, to cover them. Because of the fact that there's denudation of the skin, there could be fluid loss. You want to ensure fluid support because it can be painful. The blisters rupturing can be very painful. So you want to give analgesics for the pain and the fever. So don't forget, give your fluid, give your emollient, give your antibiotics, and what else again did we mention? Your analgesics for the pain and the fever. So it usually resolves within 1 or 2 weeks. It goes. Sometimes you might need to do some lab work. If you do your white blood cell count, they are going to be elevated. ESR is elevated. You can do culture, biopsy. If you try to culture those, lesions, just obtain some samples and you do your culture, you can grow the Staph aureus. If you biopsy the lesion, it helps you to separate it from SGS or TN. Of course, it's not going to be SGS or TN number one because they will not tell you that the person has used a drug. That's number one. Number two, SGS or TN are going to be affecting the mucosal surface. So they already told us in the question stem that there is perioral crusting, but there is peering of the mucosa. So you are not going to be thinking of SGS and TN. So it's even waste of time to be biopsying. But when you biopsy, what do you see? You are going to see intraepidermal cleavage and granular layer blisters. We have said it already. Blister formation at the granular layer with intraepidermal fissure or separation. It lacks inflammatory cell infiltrate. Yeah. So what do? Give your IV antibiotics. You give your nafcillin, which are the antistaphylococcal or the vancomycin, your fluid, and your analgesics. That is all about SSS. Each timer. So each timer is just more like an ulcer. That is more like a progression of your impetigo. But now it's not confined to the epidermal surface. So it's going down to the dermis, right? So they appear punched out. So let's see how it looks like. So okay. So this is eczema. A very common example is eczema granulosa, gangrenosum, eczema gangrenosum from Pseudomonas. So people that have Pseudomonas bacteremia usually develop this kind of lesion. So you just see that punched out, ulcer that is deep. Think about each time out. So it's a progression of impetigo. So the diagnosis is clinical. It's clinical. We are talking about the three: your impetigo, your SSS, or your ecthyma. It's clinical. You can do your gram stain or culture to identify the causative organisms, which we have talked about. The basic antibiotic you want to use is antibiotic that can cover both your strep and your staphylococcus, depending on what you are looking at. So if it's the non-bullous, definitely you have to use something that can cover staph and strep. If it's bullous, you are definitely going to use something that must cover your staph, right? So if it's mild, just give your topical mupirocin for the non-bullous. If it's bullous, there's nothing like topical mupirocin. You have to give oral antibiotics. And the commonest antibiotic that they usually talk about is cephalexin, because cephalexin can cover both staph and your strep. But sometimes you might see dicloxazilin in your question stem. But why I'm not very particular about this is that this only covers for Staph aureus. It only covers for Staph aureus. But there's an acronym I usually use, and that is DC. DC for when it's severe. DC, your D for your dicloxazilin, and your C for your cephalexin, oral. But if you have a very high index for MRSA, when you did your culture, you notice that the organism you are growing is MRSA. That's methicillin resistant. So that means you cannot be using stuff like dicloxazilin again. So you have to use your DCT. And what does it entail? Your doxycycline, for your D, your C for your clindamycin, and your T for your trimethoprim sulfamethoxazole. We are going to be talking about this DC, DCT a lot. By the time we get to folliculitis, we are going to come down to our DC and our DCT. So many bacterial infections that involve DC and even cellulitis involve DC and DCT. So we have to know, this acronym. We have talked about SSS, just use your ampicillin vancomycin. The child can return to school after 24 hours of initiation of therapy. At that point, the child is no longer infectious. So what are the complications? Because we know that impetigo can be caused by strep, particularly the non-bullous type. So they can develop the acute post-streptococcal glomerulonephritis after like 2 or 3 weeks after the skin infection. Bullous impetigo can lead to staphylococcal scalded skin syndrome. So we are done with the epidermal ones. So moving downwards to the ones that involve the dermis and the subcutaneous tissue. And the one we are going to be talking about first is cellulitis. So, So cellulitis is a deep skin infection involving the dermis and the subcutaneous tissue, right? Very important to remember the landmark, the dermis and the subcutaneous tissue. We also have the one that involves from the epidermis down to the dermis, superficial part of the dermis, and that's what we call erysipelas, and we are going to talk about it. So it was merged with cellulitis. I don't know why. Maybe because they kind of present similar, but it was merged with cellulitis. But cellulitis involve the dermis as well as the subcutaneous tissue. So what are the organisms that cause cellulitis? What you just need to ask yourself is that, is it purulent or non-purulent? Is it purulent or non-purulent? If it is purulent, definitely it is Staphylococcus aureus. If it's non-purulent, okay, I can think of group A, Streptococcus. Very easy. How does cellulitis occur? Either you have like damaged skin, either from trauma or from infection. Maybe somebody has a tinea infection in the leg, or maybe injury from maybe foreign object, or just you step your leg on stone or nails or something, damaged skin, or systemic source. Either the person is immunosuppressed or the person is using intravenous drug. Something that is just introducing organism into your body, right? Systemic source. So those are the two commonest way by which somebody can get cellulitis. There are some other mechanisms too, because cellulitis is very common in the extremities, the legs, very common there. People that have conditions that impairs circulation to the extremities, they can develop cellulitis of the leg. For example, an individual with varicose vein, right? An individual with peripheral arterial disease from diabetes, they can develop cellulitis because these two conditions kind of impair blood flow to the extremities. You cannot recruit your white blood cells to take care of infections. The stasis around that area, the edema, the damage to the skin barrier can allow for easy introduction of bacteria and development of cellulitis. So don't forget, when it is purulent, what's implicating organism? Staphylococcus aureus, particularly your MRSA. So immunosuppression from maybe HIV, steroid use, diabetes, right? Intravenous drug abuse, venous stasis, varicose vein, all those things can predispose to developing cellulitis. We have some key facts there that we cannot ignore before we proceed on our discussion on cellulitis, and that is scarlet fever. So I just want to remind us that scarlet fever is one of the complication of strep pharyngitis. So we are going to get in the question stem that somebody is having fever with sore throat, and they will tell you that there's associated cervical lymphadenopathy. Then afterwards, the exanthem is going to start. So you start seeing the rash. So they will tell you the patient develops a maculopapular rash that is having a sandpaper gritty feeling. A sandpaper like rash, the fever, the cervical lymphadenopathy, and the strawberry tongue should raise our suspicion for scarlet fever. And it's one of the complications of staphylococcal pharyngitis, and it is mediated by the production of the erythrogenic toxin. I don't think we need all this toxin for our step 2. It's more like step 1 stuff. And one thing about the rash, aside the fact that it has a sandpaper feeling, is that they are blanchable. You can blanch them. You can blank them. So this is a very close differential to Kawasaki. Don't forget, in Kawasaki, you usually have the rash moving down to the extremity with extremity edema, as well as conjunctivitis. You don't have any form of conjunctivitis here, and you don't have edema of any part of the legs. So how do you treat scarlet fever? Just give your penicillin. Take care of the streptococcus organism. Penicillin, penicillin. So also, we have Salmonella typhi, and Salmonella can cause typhoid, right? In which you get the history of the patient having fever, then afterwards abdominal pain, then developing either constipation or diarrhea. So most of the time they can tell us that the diarrhea is bloody. Of course, you are thinking of maybe Shigella, Salmonella, or all those cause of bloody diarrhea. So the fever, the abdominal pain, the bloody diarrhea, or constipation. And most importantly, considering the dermatological aspect, the patient is going to develop some pinkish purples within the trunk, which you call the rose spot. So I have an image that shows what the rose spot looks like. So you're just going to see some tiny lesions here. I hope you can see the lesions I'm pointing out.
Yes.
Okay, so these are the rose spots. Rose spots. This, this. So you think about typhoid. So of course, we treat typhoid with fluoroquinolones or the third generation cephalosporins. So we usually give them Cipro or the third generation cephalosporin. And it's also high for us to remember that we might have people, existing in this carrier state for Salmonella typhi. And the commonest site, where it's being carried is the gallbladder. And how do you make diagnosis of a chronic carrier state? So when you have positivity of your culture after 12 months of resolution of symptoms. So positive stool culture 12 months after resolution of symptoms, that is a carrier state, right? Most of the time they colonize the gallbladder, and what do? Just give them Cipro for at least 1 month. So that is typically what you do. So don't forget the road spot, suggested for Salmonella typhi. So that's just more like an interruption or reminder. I won't say interruption, just a reminder. So we have talked about the risk factors for cellulitis, immunosuppression, venous stasis, diabetes causing peripheral arterial disease, trauma. All these things can predispose to developing cellulitis. And what do you see that will raise your suspicion for cellulitis? You are going to see the cardinal signs of inflammation. That's the first thing. So that lesion is going to be red, it's going to be warm, it's going to be tender, and it's going to be swollen. They are going to be flat. It is going to be flat with no well-defined demarcation. So if we look at this guy's lesion now, do we think this one is well demarcated? Dr. Miriam, do you think this lesion is well demarcated or not?
It is.
Yeah, so this is well demarcated. So definitely we cannot call this cellulitis. So because this is well demarcated and this is elevated or kind of raised. So this is, and of course you can separate, the borders of the lesion from the areas of intact skin. So this is erysipelas. This is erysipelas. For cellulitis, the lesion is going to be having cardinal signs of inflammation, and it's going to be flat, not raised, and it will not have a well-defined or a well-demarcated border. So I think I have an image. I I have an image for cellulitis, okay, to show us the way it looks like. Okay, so we can see this flat lesion. We can see that the border is not well defined. You see here, when you go to this part, scattered and the like. So, and it's present in the extremity again. So if you touch it now, it's going to feel warm. Of course, it looks red, and it can be tender. All those things should raise our suspicion for cellulitis. Yeah. So the erysipelas is a very close differential, and this is just infection that is confined to the dermis and the superficial lymphatics. It doesn't go down to the subcutaneous tissue like cellulitis. It is raised, it is well demarcated. It is raised, it is well demarcated, and the lesion of erysipelas is fast spreading, unlike cellulitis that is indolent. Cellulitis is not fast spreading to the surrounding tissue. But if they tell you that the lesion is fast spreading, it is raised, think about erysipelas. Raised, well demarcated, fast spreading areas of erythema, particularly on the face, think about erysipelas. And the organism that is implicated in erysipelas is what? Our group A strep. Our group A strep. So you can just give your penicillin to take care of that. Your penicillin, just like what we use in scarlet fever, we take care of that. So, the diagnosis is clinical. From your history and your examination finding, you can make your diagnosis. Sometimes you might need to take a wound or a blood culture to determine the sensitivity, of the microbes to a particular or to different type of antibiotics so that you know the best one to select, right? Sometimes, because this is an infection of the subcutaneous tissue, they can progress to affect the muscle, the bone, right? And sometimes they can even form an abscess. So you need to rule out the possibilities of abscess forming extension to the bone, causing osteomyelitis, and also extension into the deep fascia, right? Causing necrotizing fasciitis. So they can cause necrosis of the fascia, necrotizing fascia, which is a surgical emergency. So how do you rule out all these things? You need to do your imaging. You can do your ultrasound to show us the abscess. And of course, our CT is going to help us delineate the subcutaneous, the soft tissue, the fascia, and as well as the bone. So imaging to rule out all those things. You are not going to be using topical antibiotics for cellulitis or for erysipelas. They are deep infections. They are not like impetigo, right? So that is confined to the epidermis. No, these ones are deeper. They go as far as the subcutaneous tissue. So you must give oral antibiotic, right? Depending on the condition. So at least you must use like 5 to 10 days of oral antibiotics. But there are some times you might need to give intravenous antibiotics, particularly if the infection is confined to the face, to the hobbit rather, to the hobbit and the hand. For the hand, you have a lot of tendons there. So if you have cellulitis of the hand, they can easily spread to the tendons, causing tenosynovitis and disseminating to the deep space of the hand, leading to compartment syndrome. And you are using the hand every time. Everybody uses their hand every time. So the hand needs to be free of any form of infection, right? So there is an urgency to that. So you need to give IV antibiotics. If it's affecting the orbit, that is very dangerous. Number one, it can cost that person the eyes, the vision, and at the same time, it can spread intracranially to the brain, causing meningitis. So you don't want that to happen. Give intravenous antibiotics. And of course, if the person has some underlying immunosuppression, diabetes mellitus, immunosuppression from any other thing, it has gotten into the systems already becoming widespread. It's like sepsis, osteomyelitis, complications like that. You need to give IV antibiotics. So complications like osteomyelitis, dissemination into the systems causing sepsis, immunosuppression, diabetes mellitus, hand or orbital involvement, you must give IV antibiotics, and also in extremes of ages because of their immunity. The elderly, the younger people, give them IV antibiotics. Otherwise, if it's just a normal LD adolescent, you can just give your oral antibiotics for 5 to 10 days. Now, what type of antibiotics do we give? We have already said it. If it okay, somebody wants to ask a question.
Yeah, I want to end. It's about to end very soon, so I can create another link.
Okay, so let me pause the record. Okay, so for the antibiotics to use to treat um, cellulitis is just very similar to what you do in patients with impetigo, right? The DC and the DCT. The
Chief,
DC.
are you sharing your screen?
Oh, oh my God! Thank you. Forgotten. Can you see? Can you see the screen now?
Yes. Are
Okay.
you recording?
Yes, yes.
Okay.
Thank you. So the antibiotics to use to treat uh patient with cellulitis is quite similar to what you do for impetigo. So always remember the DC and the DCT. The DC and the DCT, but you have to know that the antibiotics in this DC and this DCT are different. So if it's mild and you are not thinking of MRSA, okay. So before I start, let me say that. Let me say one thing. We said we already classified into the purulent and the non-purulent. I think I have a note here. Yeah, exactly. So for the purulent one, the implicating organisms include methicillin-resistant Staph aureus and methicillin-sensitive Staph aureus. The non-purulent one includes strep pyogen and methicillin-sensitive Staph aureus. So once it is purulent, it's either the methicillin sensitive Staph aureus or the methicillin resistant. If it's non-purulent, strep or your methicillin sensitive. Now, so that means that if it's non-purulent, I can give my first DC, which is our dicloxazilline or cephalexin, preferably cephalexin, so that one can cover for both your strep and your staph, your methicillin sensitive staph and your strep. But if it's purulent and you are suspecting MRSA, methicillin resistant Staph aureus, then you have to do your DCT, the other one, which includes the D for the doxycycline, the C for the clindamycin, and your T for your trimethoprim sulfamethoxazole. Please, we should not confuse them. That this D that is here is not dicloxazilline. I'm just looking for a way to just help us with the remembering. So I know that this can be confusing, but with time we'll get used to it. So the first D for your diclo and your cephalexin, taking care of your pyogen and your methicillin sensitive Staph aureus. Why once you make diagnosis of this is MRSA purulent, you are thinking MRSA, just give your doxycycline or clindamycin or Septrin. Okay. So then moving on to necrotizing fasciitis. So we don't need to actually go through all this story. We just need the clinchers. That's what is important. And first thing to say here is that necrotizing fasciitis usually occur in people that are immunosuppressed or people that have undergone surgery or people that have experienced some form of trauma to any part of their body. So immunosuppressed, surgical patients, trauma patients. And this is infection that has gone beyond the epidermis, the dermis down, from even the subcutaneous tissue down to the deep fascia, right? So it's causing infection along the facial plane. Now, one thing about this infection is that you are going to see the patient experiencing very severe pain, even worse than what you are seeing. So the proportion of the pain is going to be like far beyond what you are seeing. And most of the time it is polymicrobial. It involves a mix of the anaerobic and the aerobic bacteria. So we don't need to actually know the list of the bacteria, but don't forget Clostridium perfringens because it is part of the anaerobic one that can cause necrotizing fasciitis. So Clostridium perfringens, Clostridium perfringens, Clostridium perfringens, very important. And in about 10% of cases, you can have infection from strep pyogenes. So that's why sometimes you might give the patient penicillin to cover for this, then you can add clindamycin to neutralize the exotoxin produced from this strep pyogen, because strep pyogen will produce TSST toxin. That's the toxic shock syndrome toxin that can cause toxic shock. Part of what that toxin can cause is also necrotizing fasciitis. So you have to give an antibiotic that can suppress the production of that exotoxin, and that is clindamycin. I'm going to say it again by the time we get to the treatment. But the more I say it, the better it sticks. So don't forget, you can get the question stem pointing out to trauma or recent surgery. There's a background, there's a focus, for the infection to develop. Sometimes it can even be cellulitis. Maybe the patient had cellulitis and within few hours to few days, deteriorate to necrotizing fasciitis. So how will this patient present? The patient is going to have some systemic features like fever, chills, altered sensorium, right? Confusion, you know, dizziness, and the likes. And there's going to be excruciating pain. So there's an acute onset of pain, right? So somebody's having cellulitis before, it's painful, but suddenly you have an aggravation of that pain, which is out of proportion to your skin, findings on examination. And there's going to be presence of some bullous lesions. Although this one is not showing the bullae, but sometimes the question might tell you that you are seeing bullous lesion, and what should raise your suspicion for necrotizing fasciitis will be the color of the skin. They will tell you that it is appearing dusky, it is appearing brownish or blackish, as if there is kind of necrosis happening there. That should raise your suspicion. So the 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 inflammatory process occurs very fast, and you see the normal skin changing color to a dusky purplish brownish color, right, indicating necrosis of the skin. So don't forget, there's going to be systemic presentation like fever, like malaise, chills, and altered sensorium. Then suddenly acute pain that is excruciating out of proportion to your skin examination finding, and changes in the color of the skin. So brownish, purplish discoloration of the skin, bullous lesion, bullous lesion. Sometimes you can even dip your hand into that lesions. You can put your two fingers to separate them into layers, right? Because there's necrosis everywhere, right? And what we always talk about in our step one, the signs, right? The crepitus, because one of the organisms that is implicated in causing necrotizing fasciitis are the anaerobes. And we know that the anaerobes are very, very notorious for forming gas. Part of their metabolic pathways, they produce gas like methane, like carbon monoxide. So just imagine the gas tracking within the tissue planes. It's going to cause crepitus. So you are going to hear crepitus, as if you are stepping on dry leaves. Crepitus from the gas production. And we know that part of their metabolic product are some foul smelling agents. So you are going to experience foul smelling discharge, crepitus on physical examination, the bullous lesion, the skin discoloration, the excruciating pain. Think about necrotizing fasciitis. Think about necrotizing fasciitis. So don't forget about the crepitus. Don't forget about the foul smelling putrid discharge. Don't forget about the skin change, skin discoloration. Don't forget about the pain. And of course, you get the history of the trauma, the surgery, the immunosuppression. So we have talked about the organisms. One organism that we must not forget. Dr. Miriam, do you remember the organism that I said we should not forget for this necrotizing fasciitis?
Clostridium perfidus.
Clostridium perfringens, anaerobes, anaerobes, anaerobes. So they produce the gas, that will be causing all these crepitors, that will be causing all this foul smelling discharge. And in 10% of people, it can be from group A strep, which is our strep pyogenes, right? So it is a clinical diagnosis too. We should have a very strong suspicion from our clinical exam. We might do imaging to also confirm some of those components, particularly the gas. So what imaging are we talking about? A CT scan. We can do a CT. It's going to show us the gas accumulating within that soft tissue. And it is important to know that this is a surgical emergency. You have to do immediate surgical exploration and debridement. You have to remove all those necrotic tissue, remove all of them. So you can do a tissue culture to help you identify the causative organism, if it's the group A strep, if it's the Clostridium perfringens, if it's Staph aureus or anyone, and you know the right antibiotic to tailor, the treatment towards. Fournier's gangrene. This is one of the problems of people in urology. They deal with this guy a lot. And it's a form of necrotizing fasciitis affecting the genital area and the perineum. Fournier's gangrene, right? So, what about the treatment? Surgical emergency. You have to do surgical exploration and debridement, which is very critical. Then you place the patient on broad spectrum IV antibiotics immediately. So if you do your culture, right, and you are able to grow strep, the group A strep, what are we giving? Pen. Very easy. It is pen. When it comes to strep, it is always pen. So give penicillin G for the streptococcus, right? And just like I said, we are going to add clindamycin to reduce the exotoxin production from this strep. And of course, we must always provide coverage for the anaerobes because most of the time they are implicated. Most of the time it is polymicrobial. So give metronidazole for the anaerobes. Give metronidazole. Even clindamycin can also cover for the anaerobes. Clindamycin can cover for the anaerobes. Metronidazole can cover for the anaerobes. And sometimes we might use a third generation cephalosporin. So moving on to folliculitis. Folliculitis. Folliculitis is just inflammation and sometimes infection of the hair follicle. So the reason why they have inflammation stroke infection is that sometimes you can have folliculitis without any infection. Example, somebody with eosinophilic folliculitis. People with AIDS, people with HIV, they can have eosinophilic folliculitis. There's no infection that is causing that problem. So it's just due to the immunodeficiency state. So that's why but one thing that is constant there is that there is inflammation. We don't know if it's autoimmune, we don't know if it's microbial, we don't know if it's from anything, maybe infection, autoimmune, blah blah. We don't know, but there is inflammation. But sometimes you can have it, being caused by an infection. So that's why it's being defined as inflammation and or infection of the hair follicle. What are the implicating organisms? We need to know this. Very, very important. And what are the three organisms we just need to remember? Staphylococcus, Streptococcus, and our gram-negative bacteria, which is Pseudomonas. Like, they pass those three. Staph, Strep, and Pseudomonas. Those are the organisms that cause folliculitis if it's going to be infectious. Sometimes it can be caused by fungal, like yeast, such as Candida albicans or our Malassezia furfur. We are going to talk about this Malassezia furfur like a lot in our what's it called? In our uh, mycology section. So this guy causes a lot of problems, and we need to know it. And we should not get it confused with the dermatophyte. So we are going to talk about it because that's very, very important. Malassezia furfur, it can cause folliculitis. Candida albicans can cause folliculitis, and most commonly staph, strep, and pseudomonas. So now, what do we see to make diagnosis of folliculitis, what do we see? Very easy stuff. So let me show us the image and we see what we are looking out for. It's very easy to make diagnosis of folliculitis. So we are just going to see pustules, that is pus-filled papules surrounding the hair follicles. We can see that all these papules are emanating from the hair follicles, right? Because this is the hair. These are the pustules, right? With erythematous base. You can see the surrounding area of erythema. That's folliculitis. That is folliculitis. So sometimes you can have the infection penetrating downwards, deeper into the dermis, right? And you're having the abscess forming in that area. That's what you now call furuncle. So when you now have multiple furuncles spreading to adjacent follicles, you call that carbuncle. That is just it. So how the patient is going to present? They are going to have pain. It could be itchy. Sometimes it might be asymptomatic. Pustular lesions surrounding hair follicles, right? That is folliculitis. Just like I said, sometimes you can have the infection deep into the dermis, causing a furuncle, which is a hair follicle abscess. And when you have multiple furuncles, due to dissemination to adjacent follicle, you call that a carbuncle. So once you see this, you have to, do some immune studies to be sure that that person is not immunosuppressed. Because by the time you are seeing multiple folliculitis or furuncle or carbuncle, you have to check. Is the person diabetic? Does he have HIV? Just rule out that. So don't forget they have painful, itchy, pustular lesions surrounding the hair follicle with erythematous base. So this is, an example of a carbuncle. So you have a lot of, furuncles, coalescing together with the prolonged discharge, right, in the neck. So sometimes it can occur from immunosuppression, just like I've said, and exposure to hot tubs. So we call something hot tub folliculitis. So the implicating organism in hot tub folliculitis is Pseudomonas. Once you see hot tub folliculitis, you could just go to the option and pick Pseudomonas. So once they tell us in the question that the person swims in the hot tubs, enjoys his or her life, relaxing in hot tubs and subsequently develops puritic or painful lesions, and they show us the image, we are seeing the folliculitis. Think about um hot tub folliculitis from Pseudomonas. So they can ask, what's the implicating organisms? And sometimes it can come, it might appear in people with HIV/AIDS, just like I've said earlier, and their own variant is known as the eosinophilic folliculitis. So this is not infection mediated. It's actually not known. The pathophysiology is not well known, but we know that this patient is going to be having itchy, papular lesions. So most of the time, their own is not pustular, right? Because what is really causing the pus is just the neutrophils trying to respond to the organism. But here, there's no organism to respond to. So it's just most of the time puritic papules surrounding the hair follicles. And of course, the question is going to tell us the person has background HIV/AIDS. We think about eosinophilic folliculitis. And what is going to raise our suspicion is that when we give the person standard treatment of folliculitis, the person is not going to respond. So we think about, eosinophilic folliculitis from HIV/AIDS or folliculitis from fungi. Folliculitis from fungi like the Malassezia furfur and the Candida. So what is going to help us is when you do our KOH preparation of biopsy, which I'm going to talk about shortly. There's something I want to mention here, but I think I'm forgetting something. But let's move. Maybe as I move down, I'm going to remember. So the diagnosis is clinical, right? But sometimes when you start your treatment, and the treatment is also the DCT, this DC treatment I've been talking about. The DC treatment that we use in people with impetigo, people with cellulitis. We're also using it here in folliculitis. The DCT. So most of the time your history is sufficient, your clinical, your your clinical examination, looking at the appearance of the lesion, can tell you what you are dealing with. When you start your standard treatment and you're not getting any response, you can do further investigation by doing your KOH prep to see is this coming from Candida or Malassezia four, or you do a biopsy in which you are going to be seeing eosinophilic infiltrate, which is going to raise our suspicion for eosinophilic folliculitis in people with HIV/AIDS. Good. So how do we treat? Don't forget your DC and your DCT, your DC and your DCT, your DC and your DCT. But first of all, if it's just mild, right, you can start your topical antibiotics, because we ask ourselves, what is the implicating organism here? What is implicating organisms? We said the implicating organism includes gram-negative, particularly Pseudomonas, staph, and strep. If it's going to be from Pseudomonas, that is, the person is playing in hot tubs, we are not going to give the person anything because it is self-limiting. It doesn't require treatment unless it is very severe and widespread. That's when you now give the person anti-pseudomonal agent like ciprofloxacin. But if it's not due to hot tub exposure and we are thinking of another thing, maybe from our culture or the likes, and it's demonstrating staph or strep, then we need to use another thing. So if it's mild, you give your topical antibiotics, and that is mupirocin. We have said it that mupirocin works for both staph and strep. So give your mupirocin if it's superficial and mild, right? But if it's getting severe and widespread, then you need to escalate to your DC and your DCT, DC and DCT, DC and DCT. So if it's severe and it is not due to MRSA, just give your dicloxazilin or your cephalexin orally. But if you are thinking it is MRSA, if there's a high suspicion for MRSA, that means you have to use your DCT, which is your doxycycline, your clindamycin, or your trimethoprim sulfamethoxazole. That is the way it works. Very easy. So we can say that this management is just exactly like the management for impetigo. If it's just mild, topical antibiotic, mupirocin. If it's severe, you now need to separate. Is it MRSA or not? If it's not MRSA, DC. If it's MRSA, DCT. That is it. If there is high suspicion for hot tub folliculitis, the person is swimming in hot tub and the bacteria was, cultured in Pseudomonas, or even if they don't culture any bacteria, but you have seen in the question state that the person swims in hot tub, think about Pseudomonas. If it's severe, give your Cipro. If it's not severe, give your um just do your reassurance, and the person doesn't need any treatment. So I've not seen any question on this. Well, we should have it at the back of our mind. Acne vulgaris. So we cannot go for an exam and we don't know acne in and out. In fact, we should be thanking God in the exam by the time we see acne, because it's going to be bonus. It's going to be bonus. Acne is very common, very, very common in adolescents. That's the first thing. We need to know the four pathways by which acne develops. And the first thing I'm going to say is this second point, the development of the comedones. Very, very important stuff. The development of the comedones. And what do we mean by the word comedones? Comedones are just like lesions that have two colors, the white and the black. The white and the black. And what is responsible for forming the comedones is occlusion of the pilosebaceous unit. So the pilosebaceous unit is just talking about the hair follicles and the surrounding sebaceous glands, right? The pilo, hair follicle, and the sebaceous component, which is a gland surrounding it, secreting sebum into it. Now, when you have occlusion of that hair follicle from keratin, the sebum that is being secreted into the hair follicle cannot get upwards to the surface. So let me show us what I'm talking about. So this is the hair follicle. You usually have the sebaceous gland around it like this, secreting sebum to keep the skin supple here. So you are going to having the sebum translocating upwards, making the skin look fresh and nice. Now, if there's problem with keratin, because you have your keratinocytes infiltrating everywhere, they are everywhere. So they produce keratin. If you don't have time to time shedding of those keratin, they are going to keep clogging these hair follicles, and your sebum that you are secreting here will not be able to move out to the skin surface. So it's going to be gravitating here, accumulating. Now, that can lead to formation of comedones in this hair follicle. And how do they appear? They can appear black or white. Now, they appear black when it is open. When this follicle is open, they appear black, because when it is open, it is prone to oxidation. So that's where I remember it. Once it is open, it is prone to oxidation, right? And it becomes blackish. When it is closed, total occlusion, right? It appears white because it cannot be oxidized. So let me show us a picture of what I'm talking about. I think I have it here. So these are the black comedones. Dr. Miriam, can you see this?
Yes.
So this blackish tiny spot, this is comedone. These are just comedone. So this is a mildest form of acne. This is a mildest form of acne. These ones here, they are the white comedones. So this means these ones are open comedones and these ones are closed comedone, because you cannot have the oxidizing agent penetrating into a closed comedone. And when they cannot penetrate, they cannot make it black. Because once it gets oxidized, it becomes blackish. But once it is not oxidized, it becomes whitish. So this is one form of acne, comedome or comedomal acne. Now, moving on to the next factor. What is the next factor? Either this person is an adolescent, a guy that is secreting a lot of androgens. And what does this androgen cause? The androgens will stimulate the sebaceous gland to produce a lot of sebum. Now, overproduction of sebum from the androgen stimulation, occlusion of the pilosebaceous unit by abnormal keratinization will cause the sebum to keep accumulating. And what will happen? A bacteria will be growing into that sebum. There's a sebum-loving bacteria, a fat or a lipid-loving bacteria, which you call Cutibacterium acne or Propionibacterium. That bacterium likes gravitating where you have a lot of sebum. Now, that bacteria is now going to start, feeding on that sebum, provoking inflammatory response. So that's how the four sequence happen. The first one is when you have formation of the comedones by occlusion of the pilosebaceous unit. When the person has come of age, increase hormonal activation from the androgen, stimulating the sebaceous gland to produce a lot of sebum. The Cutibacterium growing into that sebum, provoking the inflammation. Now, when it now gets to this inflammatory stage, you call that inflammatory acne. What are you going to see in somebody with inflammatory acne? Now, you are not going to be seeing those comedome again. Now, this person is now going to be having erythematous lesion filled with papules and pustules. So let us go back and see this one. So, okay, I don't think I have it. I don't think I have it, but I think I have it when I was talking about the treatment. I think there's a small picture there that depicts. Yeah. So, okay, let me see. Yeah. So, Dr. Marian, can you appreciate this black comedone, right? So these are the comedomal acne. Now, we are now seeing erythematous lesions. These are not comedones. These are not black or white. They are red. And we can see the papules and the pustules. So this is inflammatory acne. Now, inflammatory acne is characterized by small papules or pustules less than 5 millimeters. It can now provoke serious inflammation that will now change all these guys to what? To nodules. They apply big, more than 5 cm, nodular, and cystic. They will start, forming cavities lined with epithelium containing fluid, which are known as cysts. So we call that nodulocystic acne. And sometimes they can match together to form sinus tract that will keep discharging. They will keep releasing their content. You just like a tap. You just be discharging. You just see them. See all those guys. I don't know if you have seen people that have all this severe acne. If they press the stuff like this, see the stuff, oozing sinus tract. And with time, they'll start healing with scarring and can disfigure the face. So that is the three spectrum that I want us to hold, and the treatment varies depending on the spectrum. So we have talked about the pathophysiology. We have talked about now still on the pathophysiology. Sometimes it can be induced by drugs, medications such as steroids and lithium. So steroids is very easy to remember. So that is why steroids is never part of the treatment option for acne. When you are talking to somebody and you tell the person, please, I have acne in my face, so what can I use? And the person is saying steroid. You know that the person doesn't know what he or she is saying. You cannot use steroid to be treating acne. In fact, steroid can cause acne. And of course, lithium. So many people used to know lithium, causing maybe nephrogenic DI or thyroid issues. Lithium can also cause acne. In fact, the commonest dermatological manifestation of lithium is acneiform eruption. Very, very important stuff. Lithium can cause acne. Steroid can cause acne. What other things? Topical occlusion. So people that use a lot of makeups, bombard their face with makeup. That stuff can occlude all those pilosebaceous units and lead to development of the comedones, right? And also in some hyperandrogenic states, people with congenital adrenal hyperplasia, people with PCOS, people with Cushing syndrome, all these conditions can lead to overproduction of androgens that can lead to stimulation of the sebaceous gland, producing a lot of sebum, developing acne. So we have talked about the three stages, right? The first one is the comedomal stage, where you just have the open and the closed comedones. And what is causing that is just occlusion of the pilosebaceous, unit only, right? Um, but by the time you start having secretion of more sebum and your Cutibacterium growing into it, causing inflammation, it develops the inflammatory comedone. And what you are going to see is erythematous background with numerous papules and pustules. Please ignore this one. Then the last one is now the nodulocystic variant, where you now start seeing nodules more than 5 millimeters and cysts, with discharging sinus tract, healing by scar. That is a nodulocystic form. That's the most severe form, right? That's the most severe form. So, and picking at the lesion. So when they try to be opening, touching the lesion can worsen the scarring. So acne usually develops at puberty because that's when you have the androgen secretion peaking, right? Um, okay, that's when you have the androgen secretion peaking, and it's very common in males because we produce more androgens than females. Women in their 20s can also have a variant that flares with menstruation. Please don't worry yourself too much about this. It's not very high yield. Women can have it fine and can flare with menstruation. But don't forget the drug induced one from lithium and from steroids. Very important stuff. And the drug induced ones are monomorphic, meaning that you don't have a lot of inflammatory lesions. You don't have papules, pustules, nodules, or cysts occurring together. You only have one thing. And what is that? The papules. You just see papules, just see papules. And because they are induced from the medication, they will not respond to our standard acne therapy that we are going to look at shortly. So the only thing you can do in response to the drug induced is what? To stop using that drug, stop using that steroid, you know. And there's also another form that I call acne mechanica, and that's due to pressure or friction. So anywhere that is subjected to too much pressure, too much friction can damage the skin there. The keratinocyte can occlude the pilosebaceous unit. You can have occlusion from retention of sweat, retention of sebum, uh, dirt and debris. from the constant friction and irritation. And when there's occlusion of the pilosebaceous unit, we know what is going to happen next. So acne. So you have to eliminate this source of the pressure for acne mechanical. So very common in people that use crutches, people that wear brass straps or heavy back, uh, people that carry heavy backpacks. Um, Ironically, erythromycin doesn't cause erythema of the sun exposure. Oh, these guys are trying to be funny. But tetracycline can cause photosensitivity rash. High yield. Doxy can cause photosensitivity rash. So if they tell you that the patient is developing photosensitivity rash, maybe in the face, and they give a list of the drugs, right? And they put some other disturbing risk factors to confuse us. Just look for Doxy. Look for Doxy, you'll be correct. You'll be correct. You'll be correct. So Doxy can cause photosensitivity rash. Diagnosis clinical, exam finding and history sufficient. Sufficient. How do you treat? So we are not going to be going through all the stuff here because it can be confusing. Let's just look at this image here, and we already know that this is going to be the comedoma acne. You can see the black, black, black. The first thing to start with is the topical retinoid. So one thing I'm going to say is that there's a progression to the way you manage acne, and it is commonly tested. They want to know if we know that progression. The first thing is to start with a topical retinoid, right? Then you escalate to adding benzoyl peroxide. You add benzoyl peroxide. If that doesn't work, you add a topical antibiotic. You add a topical antibiotic. If that doesn't work, you don't use topical antibiotic, you add an oral antibiotic. If that doesn't work, then you stop everything and you give isotretinoin. So we have said it. The starting is a retinoid. Hello? Okay.
Yeah, Chief, I wanted to ask that. So the order that you just said now, is it for all the types, comedonal, inflammatory, and the cystic?
Yeah, most of the time for the comedoma one, by the time you give your retinoid, it will be fine. So the one that requires all this escalation, usually the inflammatory and the nodulocystic. Most of the time, because comedoma is not very severe, by the time you use your topical retinoid, the person is going to be fine. But the one that might require some escalation, depending on the grade, will be the inflammatory or the nodulocystic. So how do we start? We have identified in the question stem that they are telling us that the expense of the comedones, the black spot, the white spot, and we know, okay, this is likely to be comedoma. So you just give your topical retinoid. Topical retinoid. An example of that is the tazarotene, I have a lot of adapalene. I have them here, you know, the adapalene, the tazarotene, the tretinoin, the alitretinoin. Just know one or two. But sometimes why I like them is that sometimes they won't put all these drugs there. They will just put the name, the class, which is topical retinoids. So that you are covered. You don't need to be cramming any of the adapalene or these guys. So that's that about the comedoma one. Then for the inflammatory, we are already seeing it in the question stem that they are saying there's erythematous, purple pustules in the face. You know that this is not comedoma. This is inflammatory acne. So that means that you are going to be starting with your retinoids too, but you must add something, which is your benzoyl peroxide. You must add your benzoyl peroxide so that you can kill off that Cutibacterium, because our retinoids are comedolytic. They can break those occlusions in the pilosebaceous unit. But when it's getting to inflammatory acne, you already know that Cutibacterium is at work. So I need something to help me kill off that Cutibacterium. So that's why you had the benzoyl peroxide. You had the benzoyl peroxide to your retinoids. If you had your benzoyl peroxide to your retinol and that is not working, then you know that it be like say benzoyl peroxide cannot kill Cutibacterium. I have to give antibiotic that can kill it. But you will not jump to oral. You use your topical antibiotic first. And which topical antibiotic are we talking about? Clindamycin or erythromycin. So clindamycin or erythromycin is going to be used with our topical retinoid and the benzoyl peroxide. Sorry, you are not going to discontinue benzoyl peroxide. Topical retinoid plus the benzoyl peroxide plus the topical antibiotics. You know, if that doesn't work, then you now use topical retinoid, benzoyl peroxide with oral antibiotics. And which oral antibiotics are we going to use? Your tetracycline. Example, doxycycline. If it's topical antibiotic you are choosing, it's going to be Clinda or erythromycin. If it's going to be oral antibiotics, it's going to be doxycycline. Then we move down to the nodulocystic acne. So one thing to always remember about the nodulocystic acne is that you must always start with antibiotics. So once you know that, you are fine. And you know that you must combine your antibiotic with two things: your topical retinoids, your benzoyl peroxide, and your antibiotics. So you can start with topical retinoids, benzoyl peroxide, and your topical antibiotics. If that doesn't work, you now go to your topical retinoid, your benzoyl peroxide, and your oral antibiotics. If that doesn't work, you stop everything and you switch the person to oral isotretinoin. But this guy is very, very bad. You have to make sure that that patient is not pregnant. You do a TG test to rule out pregnancy every month, I think every month. And you also have to monitor the function of the liver, and you have to check the lipid profile, your cholesterol and triglycerides. So we are going to go back, to what we have here. So your topical retinoids are the most effective topical agent for comedoma. So if you see that this is comedoma, just give topical retinoid and leave. The person is going to be okay. Sometimes you might need to add topical benzoyl peroxide to kill the Cutibacterium acnes, particularly when you see that it's now getting to inflammatory acnes, right? So the first stage of inflammatory acne, you give your benzoyl peroxide with your retinoid. If that doesn't work, you give your benzoyl peroxide, your retinoid with topical antibiotics, which is Clinda or Erythro. If that doesn't work, you give your retinoid, benzoyl peroxide with oral antibiotic, which is Doxy. Definitely that should take care of it. But if it's nodulocystic, you know that this one you have to start with antibiotics. So it's going to be your topical retinoid, your benzoyl peroxide with your topical antibiotics. If that doesn't work, your retinoid, benzoyl peroxide with oral antibiotic. If that doesn't work, stop everything, give isotretinoin. So you have to look at the question, which one have they done? Which stage are they? So that you know where to go to next. If they have tried topical antibiotics, then you know that it's going to be oral antibiotic you are going to next. If they have used oral antibiotics, then you know that you are going to cancel everything and start your isotretinoin. So that's all what is summarized here. Isotretinoin is a teratogen and it elevates the liver function test. So all the liver markers are going to be elevated. So you need to do periodic blood tests, to check the liver function, to check the level of cholesterol and triglycerides. And if the patient is not pregnant, you need to place the patient on at least two forms of contraception, the hormonal plus the barrier. So maybe diaphragm, condom, with your hormonal. And, you have to monitor with the baseline. You have done your baseline before you comment. And you have to ensure you are doing serial pregnancy test, I think about monthly. We don't need to know that, it's not very important. Just know that give contraception, rule out pregnancy before you start it, give contraception if the person is not pregnant, periodic checking of your LFT and your cholesterol triglyceride level. So moving on to the pilonidal. So this is very easy. This is just forming abscess at the sacrococcygeal region. So abscess formed at the superior intergluteal cleft. This is the superior part of the midline of the intergluteal cleft. This is the superior part. So Anybody that's having an abscess there, we call that a pilonidal cyst, right? So the pathophysiology there is that there is, or the risk factor, let me say risk factor, because I'm not having so much explanation, so I can't say pathophysiology. The risk factor is a patient that is obese or somebody that has excessive hair growth. So you have a local penetration of the hair, into that intergluteal cleft that can irritate that area, leading to the inflammation, causing abscess formation. So once the abscess develop, you notice that that area is going to be tender. You can see an erythematous fluctuant warm mass in that area. So you know that, okay, there's likely to be an abscess. And sometimes you can see the abscess discharging, the pus, and it can affect the surrounding skin, causing cellulitis. So once cellulitis is present, you need to give antibiotics. If there's no cellulitis, you don't need to give antibiotics. Just drain the abscess and put your occlusive dress in there. That is all. And you have to ensure that the person is not doing stuff that can make it recur. You have to ensure like local hygiene of that area, and you have to cut out all the hair within that sacrococcygeal area. Cut all the hair out. Sometimes the abscess can, um, start forming sinus tract. The sinus tract can lead to an abnormal communication with the anus, leading to perianal fistula. So part of the complications is perianal fistula. So you can watch out for that. So that means they can give us a question saying somebody has a mass, fluctuant tender mass in the superior part of the intergluteal cleft. You already know that this is pilonidal cyst. And they can ask us, what's the potential complication? Abnormal communication with the anus, which is perianal fistula, perianal fistula, perianal fistula. So how do you treat it? Diagnosis is clinical. No big stuff. Diagnosis is clinical. So this is the progression of acne they are talking about. So topical benzoyl retinoid, antibiotic, oral antibiotic. I've talked about that. So antibiotic is not needed for pilonidal cysts unless cellulitis is present. So if antibiotics are prescribed, both aerobic and anaerobic coverage is required because you have to be able to cover both the aerobes and the anaerobes. How do you treat? I've said it. Just do incision and drainage of the abscess. Then you do a sterile packing of the wound. If there is a sinus tract, forming, discharging purulent material, you have to excise that discharging sinus tract if it is present. Ensure good local hygiene and shaving of the sacrococcygeal skin, because don't forget it is skin that is it is the hair follicles that is irritating the skin, causing the inflammation and the abscess. So you have to shave off that skin to prevent recurrence. That's that about pilonidal cyst. So we are going to be ending with leprosy. So leprosy is a disease of the skin and the peripheral nerve. So we already know this. Leprosy is caused by Mycobacterium leprae, which is an acid-fast bacteria. Very common in Southwest United States and in developing countries. You know, it's caused by the Mycobacterium leprae, and it leads to formation of chronic granuloma. Very important stuff. There is granuloma formation in Mycobacterium leprae, just like Mycobacterium tuberculosis, and it has affinity for staying in cold regions of the body. Cool, not cold, but cool region of the body, like the skin, like the nerves, the mucous membrane, the upper respiratory tract, and the eyes. So these are the areas where you see the damage: the nerves, the skin, the nerves, the skin. So you are going to have the bacteria inoculating into the skin, and you are going to have an inflammatory response. The bacteria is going to be destroying a lot of tissues within the skin. And when it destroys the skin, what are we going to see? We're going to see hypopigmentation. So that area is going to look hypopigmented, it's going to look white, right? Hypoaesthetic because it has destroyed the nerves that are there. So you cannot feel sensation again. So you see the question saying somebody's having hypopigmented skin lesions or plaques or patch, plaque, that is hypopigmented, with hypoesthesia. They cannot feel anything. And the area is hairless. It has taken off the hair in that area. This is leprosy. The nerves are going to be thickened because the granulomas are going to make the nerves appear thick. And it also destroys the peripheral nerves. So like the ulnar nerves, the common fibular nerve. So it can destroy the peripheral nerve like the ulnar nerve. And you see the patient presenting with claw hands. Claw hands. It can destroy the common fibular nerve. The patient can present with foot drop. So don't be surprised. So these are the basic presentation we should have at the back of our mind that helps us make the diagnosis quick. Hypopigmented, hypoesthetic, hairless skin lesions with peripheral nerve palsy should read a suspicion for leprosy. So the two extremes, the tubercular form and the lepromatous form. So the tubercular form is the best. It's milder. Reason being that the cellular mediated immunity is stronger here. That is the TFR1 pathway. They are stronger here. They can contain infection, and they don't allow the Mycobacterium leprae to be feeding on, to be destroying the tissues like the skin, like the nerves. So we are just going to see one or two localized hypopigmented aesthetic plaques. But for lepromatous, the bacteria is feasting. It is feasting because the cell-mediated immunity here is weak. It is weak. So don't forget, it is the cell-mediated immunity that responds to chronic infections like leprosy, like TB, not humoral. It's not involving antibodies. So if the cell-mediated immunity is weak, it becomes a problem. So lepromatous form, they have a very weak cell-mediated immunity, and the only harm of the T cell that is responding to the bacteria here is the THR2, which plays a role in allergy. It cannot do much. So the bacteria is just jolling around, destroying the skin, destroying the nerves, destroying the bone, and every other thing. So you are going to be seeing multiple plaques, multiple patch, multiple nodules, right? It disfigures the face, particularly the nose, and they are going to have a lot of granuloma lesions there, giving them a lionel fascie. So they have this lion-like face. There's going to be hair loss in the eyebrow and the lashes. That's what you call maladrosis. Maladrosis should raise your suspicion for leprosy too. They have a hair loss in their eyebrows. I'm going to show us. It destroys the septum of the nose. They can have septal perforation from the granuloma. So they have a lot of widespread granulomatous lesion because of the weak cell-mediated immunity. Just look at this person's face here. So you can see the lesions, granulomatous lesions everywhere. You can see the nose, you know. So this is it. We can see the the hypopigmented areas, right? If you touch this person now, if you try to pinch the person, it's not going to feel anything. Hypoesthetic, hairless, you know, um, hypopigmented skin lesions, typical for leprosy. How do we make our diagnosis? How do we make our diagnosis? We can do skin scraping, or you can do a punch biopsy. You can scrape the skin, just scrape those areas, or you just do a punch biopsy. By the time we start talking about the skin cancers now, we are going to be making mention of a lot of biopsy. The punch biopsy, the excisional biopsy, the shave biopsy. So you just do like, obtain a section. So punch biopsy will not really give you a full thickness, right? Just take a portion, scrape the skin, and you subject it to your acid fast staining. And we know that the Mycobacterium leprae is acid fast, right? So once we do the xenesin stain, we'll be able to demonstrate that organism, and you can make our diagnosis, right? The lepromine test is not to make diagnosis. The lepromine test is just to separate between the tubercular form and the lepromatous form. The base of this test is just to get the the leprae antigen. You inject it into the skin within the forearm, and you check for induration. So we already know that the tubercular form the cell-mediated immunity is strong. So they will respond to that antigen, and there's going to be inflammatory response. So you are going to see in duration more than 5 millimeter. You know that this is the tuberculous form. But for the lepromatous form, they don't have any cell-mediated immunity to mount against the antigen. So you are not going to see any change. So that should raise your suspicion for lepromatous form of leprosy. So your diagnosis is skin scraping and your punch biopsy, and you do your senescence staining of your samples. How do you treat? For the tuberculous form, the immunity is very strong, so you don't need much stuff to do. Just give your dapsone and your rifampicin. Person is going to be all right. But if it's lepromatous, you need to assist that person. So in addition to giving dapsone and rifampicin or rifampin, you add your clofazimine. So you are going to give 3 drugs for lepromatous: your dapsone, your rifampin, and your clofazimine. Or if it's multibacillary, of course, someone that has lepromatous form will definitely have a multibacillary leprosy. And this means that you're having more than 5 lesions. When you have more than 5 skin lesions, that is multibacillary. You have to give clofazimine in that person. Clofazimine. So we come to the end of the bacterial, and then we continue some other time. Mr. Marian, do you have any question? We'll call it a day.
None at all.
Okay. So that means I'm going to record the other videos later, and I'll upload it. Thank you so much for your
Okay.
time, Dr. Marian. I really appreciate
Thank you,
it.
Chief. Thank you.